Today, our final session is about community-based rehabilitation, insights on formulating a rehabilitation plan for the patient with chronic psychiatric illness. Our speaker is Dr. Rakesh Chander Sir, Assistant Professor, National Apex Coordinating Center for Tele MANAS, Dept. of Psychiatry, NIMHANS, Bangalore.
The chairpersons for the session will be Dr. Maushmi Mukherjee ma'am and Dr. L. Sriram Sir. Dr. Maushmi Mukherjee ma'am is a professor in the Department of Psychiatry in JIPMER, Pondicherry. She has did a DPM from NIMHANS and DNB from GMCH Chandigarh, and she has published over 30 papers in high-impact international journals and participated in over 50 national and international CME and workshops. We invite you to the dais, ma'am. Next, Dr. L. Sriram Sir. He is a Senior Assistant Professor in the Department of Psychiatry, TKMCH. He did his MBBS from Government Tirunelveli Medical College and MD Psychiatry from Madras Medical College. He is working in the Department of Psychiatry in Government Thuthukudi Medical College Hospital for the past 12 years. We invite you to the dais, sir. The session is over to you, sir and ma'am. You can introduce the speaker.
Good afternoon. First of all, I'd like to thank Dr. Panneerselvan sir and Suvasaran sir for giving this wonderful opportunity. And here we introduce the speaker, Dr. Rakesh Chander. He did his MBBS from Government Medical College, Hospital Vellore, Tamil Nadu, and did his MD Psychiatry from National Institute of Mental Health and Neurosciences. And currently, and he's a vast experience in the field of community psychiatry from NIMHANS, and currently Assistant Professor, Apex Coordinating Center for Tele MANAS under the National Tele Mental Health Program, Ministry of Health and Family Welfare, Government of India, NIMHANS, Bangalore. And to his credit, he had more than 31 original research papers, book chapters and manuals. His areas of interest include community psychiatry, including capacity building, mental health promotion and prevention by involving activities that create awareness among public and target groups on mental health, and psychiatric rehabilitation, particularly treating and managing severe mental illness, and special interest in common mental disorders and substance use disorders among children and adolescent population.
Good evening, sir. Welcome to this session. So as we all know, you will be talking on community-based rehabilitation in chronic psychiatric patients. Tele MANAS is one of the pioneering projects of the Government of India with the help of NIMHANS. And I hope, sir, you will be touching the topic of rehabilitation in mental retardation, intellectual disability, chronic mental illness, substance abuse, maybe chronic pain syndromes.
Check. Okay. Yes. Thank you, sir and madam, for that introduction. I think I'll just go off stage and I'll try to interact with. I think there are very less people. So yes, madam, I'll try to cover the topics. I have probably given two types of topics to cover. The organizers wanted me to talk on CBR and then probably to formulate a plan for the residents in an exam perspective. Am I audible? Okay, fine. So maybe I can go downstairs. I think usually I like the way this whole topic is placed. So rehabilitation, people feel that it has to come at the end. Probably I will say how it can still be from the top. But I also understand that the other topics are put up first. That gives us a lead of why community-based rehabilitation comes in the end, but it's not the least preferred also in the current trends. Okay, usually post-tea, people would want to push off. I think I'm in between yourself and the sunset, since it's a specialty here in Kanyakumari. I'll try to make it very interesting as possible. That's how community-based rehabilitation is. So I will try to, before I go, I also, since associated with the Tele MANAS, how many of you know what Tele MANAS is? You can raise your hands. Okay, fine. Tele MANAS is one of the initiatives that's recently happened. Last year we had the central government releasing a budget for a national telemental program. So you have all the services, mental health services on the online platform. and we are training all the states across the country. So NIMHANS is the Apex Coordinating Center, and it's call-based, audio-based format at this point in time. And I'm glad to share the information that Tamil Nadu is getting the maximum calls. We have received more than 10,000 calls comparing to other states which are still lagging behind. So kudos to the team in Tamil Nadu. So with that news, I'll go into the presentation. So how many of you here, I know rehabilitation, I mean, I don't know how rehabilitation is point of emphasis here in your curriculum. So how many of you are confident in formulating a rehabilitation plan? You can raise your hands. If you want more anonymity, probably you guys can close your eyes and then raise your hands. How many of you are confident? No one. Okay, fine. Okay, what is rehabilitation in severe mental illness? I'm going to stick to severe mental illness. Of course, it could involve not only schizophrenia, it could also involve other illnesses which are chronic and disabling. Okay, so what comes to our mind when we hear the term rehabilitation? So we have a lot of questions. First of all, what it is? What is rehabilitation? What is recovery? What is remission? What is relapse? Where does rehabilitation stand there? Does it start from the beginning? Does hospitals get involved in all these things? What principle is it based on? And who provides it and where does it start from? And what is its ultimate goal? So next few slides, I'll try to present that. So as we all know, we all come under this UNCRPD, that is the United Nations Conventions for Rights of Persons with Disability. So under that, India has also ratified that convention. That means that it is also obliged to take care of its citizens who are all disabled to have inherent dignity and individual autonomy in taking care of their lives, and without any discrimination and reasonable accommodation, with full and effective participation with inclusion in the society. So with this rehabilitation, with these principles, have to provide an emotional, social and intellectual skills which probably would have been acquired by these patients earlier on. Probably they would have lost it, or they would have had some deficits during the course of the illness, and rehabilitation is a part where you probably have to restore that, so that they live, learn and work in the community rather than be institutionalized and with least amount of professional help. So this is what the whole alma mater of rehabilitation is. There are different concepts, definitions of rehabilitation. I'm just trying to stick to the easier pragmatic ways of it. Okay. Earlier we used to talk about, all your professors would ask this question, what is handicap, what is impairment, what is disability? Okay, now we have all moved from that aspect to more of functioning, disability and health. What you can do with what you have is what rehabilitation is all about. So you don't focus on what you don't have, you rather focus on what you have. All right. So who provides it? Yes, when it comes to an institution level, you have a multidisciplinary team. You have a psychiatrist who will treat them with medications. Then you have a clinical psychologist who will be providing them some therapy. And then a social worker will liaise with a lot of other agencies. And then occupational therapist probably will give them some vocational skills and all those sorts. So all these people will work with a common cause, that is to improve not only to reduce the symptoms but also to improve their functioning in terms of the social life, and for which each of them will be holding responsibility mutually. So the key components of a multidisciplinary work is you first understand the patient by doing assessments, and then you provide treatment and care, and you collaborate with each other. So a lot of times once you're done with your course, you might become a standalone practitioner. You might have not an opportunity to work with multidisciplinary team. So how does a standalone practitioner continue to be a rehabilitation expert is also one thing that probably you need to learn in the long run. And then team management and administrative skills. These are new things that probably not many of us would be taught. We just know how to manage acute care in terms of an aggressive patient or a violent patient. So what after? As Professor Vikas Menon mentioned, probably during the maintenance phase, you need to discuss more on vocational inputs is one thing which will close the loop for the whole patient, for the patient to have a holistic recovery. And then, of course, yes, interpersonal skills, which not only for the patient but also for us. All right. So you need to break some barriers within yourselves. You need to rehabilitate yourself in terms of improving your soft skills and social skills as well. Right. So I'm going to stick to this part, but I will be giving some evidence which will be, applied for what Madam mentioned about substance use disorders and IDD as well. But persistent psychopathology and market instability in terms of frequency in relapses and social maladaptations. These are the most needy groups. It could be across disorders, not only limited to these 3 disorders. All right. So the intervention strategies. So yes, as we know, we all do this day in and day out. We do acute management. We do symptom reduction by treating the patients with medications, and then we address the residual symptoms, say by augmenting with any strategies, including therapies, and then or you educate the family, lower their expectations when the prognosis is bad, and we tell them how to prevent relapses. We teach them warning signs to bring them to hospital when you have all these things. And then, if at all these things doesn't happen, you have some, protocols for tackling treatment resistance. So all these things you do at the hospital level. And yes, if you have a multidisciplinary team which works for the, rehabilitation part, you go a step forward, which I will be discussing later on. So, but mind you, doesn't mean rehabilitation starts from the next step. This is also inclusive of rehabilitation, is what I'm trying to say. So when you, the tablet that you start from the beginning, imagine if a person with schizophrenia seems to, you feel that this person might need a long-term treatment. So the medication that you choose might in the long run lead to a lot of side effects. It could be, a tardive dyskinesia or anything of that sort. So choosing an antipsychotic in the beginning itself would go a long way in, influencing the whole recovery process. There have been a lot of instances where you're so, emotionally attached to change your antipsychotic sometimes because you're scared once you change your antipsychotic, you feel that the person is not going to improve. So you get stuck. So when only you know the goal of rehabilitation, you will be able to think, just as Doctor already mentioned, that you need to anticipate in a long focus rather than only for the acute management. So intervention strategies, as I say, rehabilitation is also included in this as well. So what is the concept of community-based rehabilitation? Then is it against hospital-based treatment? I have partially answered this already. So that means if it is provided by professionals, can it not be provided by a layperson or a standalone psychiatrist? Can an institute-based activity be translated to community-based? Have we already done that? Is the country moving towards it? Even in the past, historically as well. Can a standalone practitioner deliver CPR? So we will try to answer this as well. So this is not only to your exam-oriented, but also once you step out, we would expect more rehabilitation specialists. So, as we all know, the vision of National Mental Health Policy 14 and the MHCA 17 includes rehabilitation and community living. And more than 1/3 of severe mentally ill needing residential care in the community continues to be institutionalized. They stay within your hospital, if at least in higher institutes. And only 15% of them are engaged in skill development, in spite of more than 75% falling only with the mild and moderate category, not even severe to profound. So these people have not been given avenues to improve their skill or even maintain their skills so that they have a livelihood for themselves. So these ventures within the hospital sides into the philosophy of inclusive living. So we have to move a step outside. So that means we call it as deinstitutionalization, which facilitates societal reintegration. I would probably ask you guys to go back and probably, if you're interested, go and read about the ANS Foundation's report on the same, which is the reference that I have added here. So deinstitutionalization may mean that to create a safer, appropriate, and sustainable residential services, develop effective community-based mental health services to monitor mental health and ongoing treatment. This is ECRC is one of the initiatives of Tamil Nadu, where people are picked up from the streets and they are rehabilitated and they are sent to rehabilitation centers run by NGOs who then integrate them back to the family or provide them some vocational training skills. So we can have similar community-based mental health programs and providing support for independent and group living, so with graded supervision. So this same report also talks about how you can have a PG for a, PG means, what is that? Paying guest kind of accommodation for patients who will be having very minimal supervision, so it's almost like independent living. And the second stage will be like a halfway home where they can go and go for work and then come back to the a place where we have certain staffs who will be taking care of their mental health, and the last one would be like, living in the community but with complete, mental health support. So these are 3 levels which have been proposed by the report, which could be one of the possibilities in the long run that we are going to get these kind of facilities. So providing opportunities for maintaining health, education, and skill enhancement, which will thereby improve social interaction and empowerment. So this is so famous that you all know the CBR matrix. So if you could see, what I have tried doing is that, have anyone seen this before? Okay. So if you go, let me come from the last part, the empowerment part. So if you see advocacy and communication, community mobilization, political participation, self-help groups, and disabled people organizations. So it says that there have been certain organizations, not only the government organizations, there have been NGOs which have been participatory in voicing out the needs for the disabled. So this one which I have given examples of Vidhi, which is a private sector organization which voices out for changing in the public health policy in terms of for the women as well as the disabled community. And also we have disabled people organizations. We have a lot. One I have put it is the Association of People with Disability, who also trains. So they aid in capacity building as well. They train people like lay persons to take care of people with disability as well. And of course, once you come a step this side, you have the social responsibilities where, I think the recent news from Tamil Nadu was about, 2 persons with mental illness get married. So these are the few things. This is one of the very extreme examples that you have. But as last presentation also, we spoke during maintenance, there will be a lot of discussions about what after me. So what after me means the parents feeling like, once I am not there, so those questions keep lingering. So those are the few emotions which, or we call it as expressed emotions, which would come in the way of your treatment plan, which will come in the way of you approach the case as well if you don't understand these aspects. And then yes, we have livelihood. We have certain programs within the institute as well. One of the programs is the Roses Cafe, where persons with mental illness are involved in running a cafe under supervision of certain occupational therapists. We have other such programs as well. So this is one way of providing them a space for employment as well as providing wages or incentives for them. So with which there are other things that people do for also NGOs is creating a bank account for them, and then going forward making other cards, so and so. Right. So now that we go to the next gen. So one hand you have done acute management, you've done everything. What would you do otherwise? So you improve. There are 2 ways of focusing on rehabilitation. One way is to focusing on the patient. The other way is to alter the environment. Because at some point in time, we always follow this rule of 1/3 in psychiatry, where 1/3 of the patient go for complete remission, the middle 1/3 go for a waxing and waning course, and the rest of the 1/3 probably go for treatment resistance. So, but having said that, the right side of the 2/3 probably would need one or the other rehabilitation inputs, which probably is overseen at majority of the times. So accordingly, you go for, you either go for a cognitive therapy or you go for behavior therapy. Usually patients with schizophrenia or any other chronic illnesses lack social skills or interpersonal skills. So as a part of vocational assessment itself, social skills is one of the major things that is included. And as a part of vocational skills, one thing that is very important is motivational interviewing, because patients with severe mental illness usually have difficulty in establishing rapport with us. So spending more time interviewing them first, addressing expressed emotions from the family, not making him understand that we are on his side rather than on the family's side, or certain few simple things that you need to follow while you are performing this motivational interview. While you do this, yes, I will be talking about what are the aspects that we will cover in vocational assessment. So some rehabilitation inputs will also be included in that aspects based on the needs of the client. And then yes, as we all know, schizophrenia is almost a neurodevelopmental disorder. So you have cognitive deficits. Even the studies say that even with bipolar disorders, even though there is good inter-episodic recovery, as the chronicity increases, a number of relapses or number of episodes increase, they also tend to have a lot of cognitive deficits. So during a cognitive assessment or a neuropsychological assessment or even a bedside assessment to find out what are all the deficits, and providing tailor-made cognitive enhancement training is also one of the important aspects. And yes, we do conduct recreational sports events. People have undergone, cricket matches. They have each festival is celebrated in the institute as well as in NGOs for their recreational purposes, which needs to continue because they don't have a space to have these opportunities. And how we alter the environment? Yes, the first thing is the micro environment, where we focus on the family. Definitely, as a part of any intervention, psychoeducation is one thing which is a dictum. But when you are here, probably it would be they are expecting more than psychoeducation, or they are expecting you probably need to focus on how to handle is laziness is what they call, how to handle, because this fellow is just lying down all day, is not helping me in household chores. Probably we all have been that person, because he had an illness, it doesn't mean that he never had the skill of helping the mother even before the illness. So just something is not acquired. So those kind of expectations needs to be reflected to the mother and showed what are all the differences between his premorbid personality and what is his illness sick role that he's taking up right now, and how she can empathetically change. So for that you need to also focus on his or the caregiver's mental illness as well. And then liaising with agencies and other departments. As a part of the rehabilitation unit, you have a vocational therapist, or you have an occupational therapist, you have your psychiatric social workers, who would have a list of employers who are happy taking care or enrolling your clients with this thing. Or you can also encourage the patient who's probably in the middle 1/3, who's not that bad symptom, probably can just go help him to just find search jobs and get enrolled by himself, without probably, if he doesn't want to enclose that he has a mental illness, he can just go as any normal person and get enrolled, that's all. So in that way. And then talking about social benefits, each state has its own ways of providing benefits. I think we have disability pension, then you have exemption from, you have some reservations in employment, and then you have free bus passes, and you have housing schemes. What else? So marriage, also there are certain allowances for them. So all these things can be educated to the family, and tax exemption for the caregivers. These things could mellow down their, frustration or their financial crisis and all these stuff as well. And then advocacy, as I already mentioned, there are a lot of organizations where these parents also can be, this one association that I mentioned, it specifically works with caregivers of patients with severe mental illness. They have group meetings, and they themselves get trained, and they in turn train the laypersons to take care of patients. So they have started in Karnataka, and they have now trying to have more centers across the state. And I think they're currently operating in more than 2 districts now. So these are certain things that is also happening. So creating awareness within your district, knowing what are all avenues you have. So we are also sometimes masked by, because I don't need this armory in my treatment. So for me, risperidone and escitalopram is enough, and if required, I'll go for clozapine. I don't need an NGO called Banyan or Scarf for that matter. So if that is required, I can just tell them. That is also one type of rehabilitation model, which I would be telling later on. The last one is community awareness programs. Yes, that happens every now and then. I'm not going to get into that. So the 10 elements of community support system, to be very inclusive, is first is a responsible team. And then you have an emergency care, followed by a residential care facility if available. And of course, a lot of our patients have medical comorbidities, and so you have a medical team as well. And you can have an halfway home, you can have a supervised apartment, as I already mentioned. and then outpatient therapies, vocational training, social and recreational opportunities, and then family and network attention. So I think I've covered almost all these things. So this is what probably summarizes what a proper rehabilitation team or a community-based rehabilitation team would suffice. So I will just tell you what has happened in India so far. So we have moved away from what we call it as the lunatic asylums that the British Empire used to call, and then post-independence we moved to mental health hospitals. I think if I could remember rightly, it was Professor Vidya Sagar at the Amritsar Hospital who started family therapy units. He used to ask the patients' caregivers to tent outside the hospitals and to take care of their patients so that they also undergo training or therapy, family therapy. So that's the first concept of psychoeducation done on the hospital basis, followed by which we moved towards general hospital psychiatric units, I think it's PGI, and then other hospitals, and then extension into primary health care. I think the Sakalvara and the Raipur Rani, I think Sakalvara in Karnataka and Raipur Rani in Haryana, were the two districts or taluks where primary health care or mental health was started, and that's where the National Mental Health Program was born, followed by which I think we took almost a decade for it to function properly, and we have even rehabilitation centers in specific districts of Karnataka where they have daycare centers where your patients can go there and spend some time with specific roles. For example, in daycare center they will have certain sections like you have biscuit making, you have candle making, you have cake making, then what is that? Rangoli, all these things, and they pack it and send it, and they are also available for the market as well. So in this way, we are able to provide a sense of skill enhancement as well as employment opportunities, and thereby a sense of empowerment for themselves. So this is not only done at the institutional level but also at the primary care level. And now the introduction of Tele MANAS, all these things will also happen at in the online platform, which is what we are expecting in the next 2 or 3 years. Right. So few models, I have stuck to only few models for the sake of time because I'm not yet finished with the first half. So brokerage model, yes, this brokerage model is something what I said. I won't do anything, but I know where things exist, so I will just send you to that place. That's what brokerage model is. Then the next one is case management, where he says, yes, I have a team within myself. I will send my colleague who's a psychologist or an occupational therapist. They will do you some assessments and they will help you then and there, and we'll all be in the loop so that we will take care of you as a team. That is case management. And then assertive community treatment is you be at your home. I come to your home and I'll take care of you whenever you need me. It is as and when needed. It is without any conditions apply. It is assertive community treatment. And vocational rehabilitation, which is one of the, I think, famous questions for the PGs, which I'll elaborate in the upcoming slides. So various concepts of vocational rehabilitation, which is I have just focused on multidisciplinary approach. I've already mentioned about halfway homes. We have daycare facilities where a patient can go 9 to 4. They can choose what section they want or what activity they want. They can just go and there will be an occupational therapist who will be supervising them on that skill. They will find out what skill he has and what skill deficit he has, and they would try to, depending upon their responses, they would either enhance their skill, and they would be given also a supervising role when they are ready. In that way, they will also be incentivized. So with daycare facilities, I think they have a place to engage on a daily basis. They aim to recover in personal and social domain with minimal incentives and wages, and also they have a opportunity to interact with the community. A community meaning there will be other patients, and also there will be certain community helpers like the occupational therapists or supervisors in that manner. And then vocational rehabilitation services, which I'll come back later, and pre-vocational training, where you have just an institute which will just impart vocational skills. You can just liaise with an ITI institute where you can just send your patients. They can upgrade their skills, and then then they are on themselves. They don't help you in finding or keeping jobs. The next one is sheltered workshops, which happens in a lot of places already. It's just you take some raw materials which are available, or what is that? Things. Raw materials which are not first hand but rather second hand, and you just come up with something. Say you can either come up with a bag, or you can come up with jewelry or a terracotta item, and you can use it for business. So this is also used by different NGOs. They have come up with, I'm not mentioning their names. There's one NGO in Chennai which I was associated with, so they do that. So with that, they also provide money to the patients as well. So with this, it helps in symptom reduction, social functioning, as well as a sense of accomplishment by minimal earnings. Yes, and then this is one of the famous questions, supported employment, in which I'm just focusing on individual placement and support model. So it is usually taken care by a mental health professional. They liaise with employment specialists, which means there will be an intermediary. This is the Western concept. So we don't have someone called as employment specialist or a job coach here. So job coach usually here would be a psychiatrist or a clinical psychologist or a psychiatric nurse or a PSW. So by this way, what we are trying to do is we are trying to have a dialogue with the patient. We are trying to find out what he or she needs, and then with that we are able to give a tailor-made this thing. And as he enters a job, we not only stop there, we continue to have sessions with him, see what deficits he has in terms of interpersonal skills. Does he have problem with his job? Does he have problem with his colleagues? How that can be taken care of. So they work in tandem along with the patient, and then continue to handhold. And also the family will be engaged in motivating the patient to continue to be at work rather than having such an expressed emotions. And this transport for job, yes, sometimes these are all Western concepts. We don't have it right now, but these are few things that we have tried to incorporate at our institute as well. Right. So vocational rehabilitation services. So this is more of a very, you use a very holistic approach or an eclectic approach where you not do one particular, type of model. You tend to take bits and pieces of everything and try to give as maximum as possible. So what you do is you prepare, find, keep jobs. That means this is almost one of very comprehensive actions. I will probably elaborate when we are formulating a rehabilitation plan. So because of time constraints, I'm just moving ahead. But I'll just say this improvement in symptoms and lower hospital admission rates, greater social interaction, decrease anxiety and stress, and enhance self-esteem and confidence. This is one thing which is proved mostly in IDD and substance use disorders, then followed by psychosis. So that's one thing. Okay. Any doubts till now? Okay. Fine. So yes, formulating a rehabilitation plan. So I think we had a session on long case presentation. So probably as a exam going student, you will be caught when you have a case which is in a maintenance phase. Mostly you get cases who are in acute symptoms. You just prescribe the medications, and somewhere you just say that I will probably do some occasional something so and so later on. That is not in my focus right now. So probably the discussion never goes there. So as sir mentioned, if only you are very confident in rehabilitation aspects, probably you will going to pull your examiner there. Imagine if you are given a patient who has rehabilitation inputs, which is the primal discussion that needs to be happening. So what would you do then? So that's the Sakalvara practice, which I have been doing a couple of years ago for 3 years. So I'll just tell you this is just the usual thing that you do in history taking. So there are certain emphasis that needs to be done. Mostly as residents, we just want to get the diagnosis right. So that's what we are supposed to do, is what we think. But as an examiner's perspective, they are wanting to see you whether you are ready for the real world outside. So there's something beyond diagnosis and management. So when it comes to rehabilitation, then probably you are going to focus on or emphasize on these parts for rehabilitation inputs, if at all you get a case which is primal on rehabilitation. So age and gender, why do you think so? Because as per the age and gender, you're going to match, what kind of functioning is required for that particular person. It could be related to a social functioning also. I had a case who just, a female, a 36-year-old female divorcee who just wanted to get married again. So it could be as simple as that. So then education and occupation, of course, to see what kind of skill they have in terms of their, occupation and their educational background, whether it's still there. And then marital status, socio-economic status, which also is required at sometimes in what kind of rehabilitation they can afford. That would be helpful in that question. Of course, contact information for all the more reasons very, very obvious. Yes, so these are the most important 5 or 4 aspects that probably you need to focus on. Of course, you're just going to prognosticate the case and see where this patient is going to lie, whether in the second 1/3 or in the last 1/3. So you see the total duration of illness and how bad the episodes or the whole illness has been, and what has been the index symptom and what is the current symptom and how have they progressed with treatment response. Well, and then social. Then socio-occupational functioning while being symptomatic during remission periods, and also their performance at work before the illness started, while they were having the symptoms, and what they are doing currently. So this is very important because as we all know, the premorbid personality adjustment is one of the major prognostic factors for the illness also. So this you will emphasize on. And yeah, and these things, treatment history, how well he has responded to treatment, what is his current symptoms are. So I can see even the mic is tired. Okay. All right, so treatment history, you see what medications he has responded to, because it's very important whether he had any side effects. Side effects can simply interfere in your rehabilitation inputs. Most patients complain that they just sleep off while they are in training, while they are attending the daycare center. So those things are also important. Side effects, any residual symptoms, still symptomatic in terms of hallucinations, they are just self-absorbed. All these things needs to be identified. That is why treatment is very important even as part of rehabilitation. Medical comorbidities which are not under control, diabetes, obesity, and also substance use in terms of especially smoking would come very much into your, there'll be a lot of craving with this patient who would want to, just doesn't want to work because he wants to go out and smoke. So all these things needs to be taken into account while you, so giving more elaboration on these history aspects is very important while you're formulating a plan for rehabilitation. And of course, as I mentioned, premorbid personality and functioning. So this functioning also needs to be very in very detail. If at all you're not able to do it within the constraints of time, you will probably put it in the plan of assessment in history. What else you will ask? You can ask about what nature of jobs he has got, whether he has gotten this job by himself or somebody has recommended for him. How good is his skills in terms of jobs? Does he talk to his colleagues? Does he, talk to his boss? Why did he leave the job? If he has went into a lot of jobs, what has been the reasons? Has it been because of the symptoms, or is it something else? While the person is in the rehabilitation phase, these things are very important because he probably is in the community as well. He's not in your full control. So you are probably letting him go into the community. So understanding the violence risk and suicide, and also sometimes some medical comorbidities, at what stage they are, also needs to be understood. This, especially seizures, sometimes uncontrolled seizures, especially with mental retardation or any other, even prof psychosis, you might have that as one of the hindering factors. Yes, then comes the family's expectation. See, most of the times there are different levels of patients that come to you. One is probably a person from a rural place who's just taking care of, was usually taking care of household chores or cattle and livestock and all these things. So there's one, that kind of a category. The other spectrum would be a person who probably did his engineering, probably is not able to get a job into what his profession actually means. So this is the spectrum that you will get. So according to that, your family is going to expect what they want. So few patients, these on the other spectrum, they feel that if he's just, not doing any aggression at home, just lying down at home, I'm fine with it. I don't want anything else. That is from the family's perspective. What does the patient want? That is also important. Whether he wants to go back to take care of his parents. There's recently one patient who said, I just want to go back to cattle rearing, otherwise I just want to end my life. There's no point in my wife taking care of me. I have to take care of my wife. That is what the society norms is. So I have to, but I'm not able to do it. So these kind of perspectives from the patient also needs to be explored. And so in that way, the family can expect independence and ideal is enough for me, or he just wants to come back to his routine or his work habits that were used to be earlier on. Or I want to go a bit forward, I want him to go to work, I want him to home for the family, and I want him to get married. These are the things that probably they will ask more for. So in this way, we have different ways. One, what we say is, we find out whether they have any family members who will be able to intern them within the micro ecosystem. Then the other one is sending him to a, how many minutes do you have? 5 to 7 minutes. Okay, fine. And then we help him in finding, creating a CV, formulating a CV, having discussions, applying for interviews, going into interviews, what interview problems he has. This is what we do in vocational rehabilitation services. Then we ask him to come back and see what mistakes he made and what was his feedback, what could have been done right. So all these things, I think only if you start doing it, you would know how a person with a severe mental illness would actually respond to you. But it also depends at the last 1/3 probably is not ready for this kind of a dialogue. So at that probably you will just go for independence in ADL or promoting work habits or something. Or you can also send him to a halfway home where you have certain activities which are there. You can just get that routine there rather than at home. Right. What after me? Yes, I have mentioned about some social benefits or finding out who can be his primary caretaker, post their families. These things could be some discussions that can be done in what after me issues. Yes, then you just can do some financial support assessment. The primary caretaker, the secondary caretaker, is there how much they contribute. These are few things that you can probably analyze and ask the family to take an informed decision about what things they have. And then vocational skill assessment. So you find out what working skills he has, whether he's an unskilled laborer or a skilled laborer or a professional, what work preference he has. Most of the time, especially highly performing patients like an engineering graduate or someone doesn't want to get settled for a meager job. But if you see his skill deficits, it could be more than what he has expected. You won't be able to fulfill a job as a normal individual who's apparently normal individual who will be working. So in that way, what is there from the employee's perspective to provide us across sectors, what the probably engineering person might not have an opportunity from an IT sector. You might have to stick to probably a teaching job or something. So it happens sometimes, but each patient has its own acceptance timing. So we'll have to wait for him. Until then, you need to continue doing your other interventions like motivation interviewing or even a CBT for depression or something of that sort. So again, it's the same thing. I've just put it back. So you do all these things as a part of your management plan. So as a take-home message, yes, majority of SMIs, rehabilitation is inevitable. So assessment is inclusive of what you're doing right now. You just have to emphasize in few pointers where you need to explore your history. It's just as how you would probably hire a person for your organization. Yes, rehabilitating ourselves in terms of networking skills is vital. Having a checklist of who you want, what is your plan for the rehabilitation is very vital. Collaborative and multidisciplinary approach gives better returns rather than being a standalone practitioner. And then being innovative and harboring technology will bring you pragmatic solutions. So I think I'm done. If there are any changes in your attitude post presentation, I would be happy. If there are any clarifications you can do, I can. There are few assessment tools which are used by the institute, which might be not available for dissipation. Those are the things that I have used. Those snippets only I have used in the presentation. But if you have any materials that you want or anything of that sort, I can share it. If you can just mail it to my mail ID. All right. Thank you. Thank you for the opportunity. You got the answer? Yeah. Okay. Fine. Next question. She answered it. Name. Madam, your name? Kalipriyava. Sorry. All of the following are the factors influencing except. Okay. Okay, fine. Thank you. Yeah.
Sir, excuse me. Sir. Yes.
Yes, sir.
I'm Dr. Arul Varman,
Yes,
Associate
sir.
Professor and Head of the Department, IGM Psychiatry.
Good evening, sir.
In Pondicherry, ma'am is actually the JIPMER, their mentoring institute. You must
Yes,
be
sir.
doing for
Yes, sir.
Tele MANAS. So our institute, our college is that execution one.
Mentoring
center.
institute, yes.
Cell actually. State cell.
State cell.
Okay. So I have two issues. One is regarding the Tele MANAS. So is it only catering this people getting the counselors only, or are you planning for a second stage level? Because as you said, there are not much halfway homes or not much centers. Okay. Even almost many people are government sector, and then in Tamil Nadu, you must be aware. Last week and all, big sensational news was there. In Viluppuram, one private center was been caught. The people, mentally challenged people, they were tortured. Sexual abuse was there. It was closed. I personally visited that place.
Okay.
So having observed this, I must tell the PGs also. Maybe in future, the PGs job opportunities will be less when are coming for medical colleges or DMS
Yes.
or other things. These rehabilitation centers, they can initiate and they can run.
Yes, sir. I think probably I think there are three parts where
Yes,
I could probably
that's
respond to your question. The first question is whether Tele MANAS will be able to provide this platform. Yes. We have 2 tiers in Tele MANAS. It is currently an IVRS platform where you, just like how you call any customer care, somebody picks your call. Here it will be a counselor who will be trained in mental health, and they will be first checking what the problem the caller has. It could be as simple as a daily distress that they go through, or it could be as bad as a schizophrenia or a depression. So we were also equipping them with providing simple counseling skills that a layperson would do. So we are training them on how to provide sleep hygiene techniques, breathing exercises, time management. Those skills we are imparting them. If they're not able to, or if the client is not satisfied with this call will escalate to an in-house clinical psychologist or a psychiatrist who will be providing them even CBT or any other advanced therapy which we have. In the long run, this audio call format will move to a video call where, as per telemedicine guidelines, the psychiatrist can start prescribing medications. Now we are also linking with the DMHP sometimes off call. We call them and say this person is not picking the call, there's a suicidal risk, and there have already been some success stories where we have made sure. There was one call which I can share probably while the person was attempting suicide. His friend called, what should I do? He's locked himself inside. This person was immediately told, you break open. While they were breaking open, he was seen trying to hang himself. He was taken to the nearby DHP center. So we are also, even before technologically, we are linking with the DMHP units. Outside the call, we are just calling the DMHP center and we are linking with them. So yes, to mention your question, yes, at some point in time, it will become what all services we are able to provide in person. We are trying to provide it online. Whichever is not possible online will at least be as a brokerage model where we'll be just providing the information where they can go for in-person training. And that where we are sending, that loop will be closed, where that referral center will also be informed that this so-and-so person will be coming there, and they will also pick up the call. So this is how Tele MANAS would be. Tele MANAS actually means tele-mental health assistance and networking across states. So it's more of a networking that Tele MANAS would do from the technical platform. And to answer your second question, rehabilitation as an opportunity. I think there are a few new slides which I didn't express. This is one of the subspecialties in psychiatry which is probably overseen. There have been a lot of challenges, as you mentioned, whether this will be one of the employment opportunities for psychiatrists. At this point in time is very meager because we don't have any regular monetary incentives which is given for people who are working in rehabilitation. You can either go as a visiting consultant, probably you will be provided an honorarium. You take a weekly rounds and come back, you're just provided some honorarium for that. But there are only certain organizations which are well established who are able to provide you that monetary benefits. So if you are going to be that standalone practitioner, you're going to bring up the rehabilitation. I think there are a lot of mental block also where we feel money is the only investment that is needed, but which is not true. If you have an idea, you have a lot of private organizations which are very much into mental health. There have been a lot of corporate centers. Recently, the Tele MANAS has also signed modus operandi with the Aditya Birla Group, where they are taking up one cell in Maharashtra. So there are a lot of other, which is one Vidhi which I mentioned. So there are a lot of corporates which wants to use their CSR funds for these kind of opportunities. So if you have an idea, if you're able to convince any investor, then rehabilitation is one of the major. I think Sangat in Goa is one of the simplest way of telling you that they just work with CSR funds. They just work with even university funds across the globe. So, but they are more research oriented. They give research aspects. You can also go for interventional aspects like banyan and scarf do. So yes, answering your question, it is not very easy for someone who doesn't have enough background to start a rehabilitation service, because not because of money, but because of their because they might be first time medical doctors, first generation people who want to earn for their family. They don't have that background. Unless you're that competitive enough as a person, then probably you will be that one who brings a new idea into the community. Yes, sir, it is happening actually. There are a lot of people who are happening. I think in Karnataka there are a lot of such centers. True, possible, sir. That can be done. So they should have like minds, that's what. So if you have an idea and if you have a responsible team, you can build up your own community mental health center. I think I have answered your question, sir. Yes, thank
you. Thank you, sir, for a most informative discussion.
Now I would invite both the chairpersons to honor our speaker. I would like to invite Dr. Karthik Devanayagam sir to honor Dr. Maushumi Mukherjee ma'am, and Dr. Malayappan sir to honor Dr. Sriram sir.